our distinguished speakers. First, I would like to invite Professor Inam Pal to the stage, who is a graduate of Dow Medical College and has done surgical training in UK. Before coming back to Pakistan in 1995, he did M.SC in Surgical Science from Hammersmith Hospital and University of London. He joined AKUH in October 1995 as senior instructor and has been there ever since, where he is now a clinical professor with special interest in GI oncology. His teaching interest is in undergraduate and postgraduate training, and he holds 36 original publications in index journals. Please welcome Professor Inam Pal.
बेटा मुझे फॉरवर्ड करने का ये है चलाने का अच्छा Assalamu alaikum everyone. Firstly, thank you for giving me the opportunity to present some of my data in this gathering. I am not a laparoscopic surgeon, so I've missed the boat, it seems, from hearing so many of my colleagues speak about it. What I will talk about is my personal data. We are a group of 8 general surgeons who have been pretty consistent in our numbers over the years. As a department, the number of cases being done are many more than what I'm talking about, so please don't confuse it with the results and outcomes from AKUH. This is just one surgeon's work that I'll be talking about. So I don't know if oh, there we are. I'm looking at the past 10 or 11 years of my work. Doesn't seem to work. How do I change my slide? Can someone help me with that, please? Next slide. This is not working. Oh. So, as we've heard, I mean, there are huge developments and changes that have come about in the approach to this specific area of oncology. Screening programs are the norm in Western countries and most other developed countries. Screening is not going to happen anytime soon in our environment. Subspecialization into colorectals, upper GI, hepatopancreatic biliary, breast, all of these are happening, and I don't think there's any denial that this has to happen. It is still some distance away in our environment. For the time being, we need to decide which way we as a group are going to head. Are we going to head down organ subspecialization as is the norm in a lot of places, or should we be thinking of a different way of doing it? Minimally invasive approaches, laparoscopic, robotic, for primary tumor resections and reconstructions. The study results and all that quote, and I think again this is not something that can be disputed, that they're as good as open surgeries with much less time off as far as the recovery time frame is concerned, and the intervention associated complications like adhesions, back to work, and wound complications, all of these are better. And on top, the outcomes of the procedure itself from the perspective of recurrences and survival of these bad cancers is pretty equivalent. So that's the way to go into the future. Again, from my country's perspective, we need to ask ourselves some searching questions. Are we there? The dollar is now something like 240 and it's not available in the market. All of these things are sold in dollar terms. We don't manufacture any of this. We have to import them. The last I heard, we had run out of Prolene meshes to use in our hernia repairs at AKU, and we had to scramble to get some and use whatever was available in the market. The same is going to happen to a lot of our stapling devices, and that is the ground reality you and I live in. Neoadjuvant treatments, now they're well established, and I think they're only going to grow. The surgical role is going to be less and less, and these big major surgeries that we used to do, which used to be the thing that surgeons used to talk about and display, I think that's going to go less and less, and there will be better ways of dealing with these tumors. ERAS pathways, again, starting in colorectal surgery, are now making their way into almost all cancer surgeries. We've tried this at AKU with limited success. It requires a lot of organization, a lot of consistency, and I think until subspecialization takes hold, probably to do it consistently across a large volume of patients is going to be difficult. But that's not saying that we shouldn't do it, but it's the practical reality of it is it's easier said than done. We're trying it. We've been trying it for the past 2.5 years. I haven't achieved what we thought we might to start with. So I just wanted to share these two little clips which I've taken before I start my presentation. So how do I run this? Can I just click and it'll start playing? Okay, so yeah. So when we talk about these conferences and I look at the titles, the clip I just showed you is what comes to mind. Everything is organized, people stop at lights, they follow their lines, and things work like clockwork. So when we look at the brochures that we print and the talks that we give, that's what it seems like. This is 8:30 every morning and the crossing that one of the many crossings that I have to pass through. There's a red light in that right upper corner, and I'm stopped at the zebra crossing white line, which you can see faded right in front of my bonnet there. This is our reality, not the video clip that I showed earlier. This is where we are. And when we talk about these highly technical, highly sophisticated undertakings, we tend to totally disregard our reality, which unfortunately is a mess. That's probably the word to use for it. So we've got to keep that in mind. Anyway, moving on. This is from COLOCON. And conspicuous by its absence is our country. The white areas are areas where no data is available for cancer incidence, outcomes, and we are smack in the middle of it. We have no idea of the magnitude of the problem. We have no idea about what our results are, how people fare, and that's the bottom line. So I will come to my study now itself. I've utilized a non-traditional approach in this retrospective review. Usually in retrospective reviews, we get hold of a few residents and some students and start sifting through case notes of patients and try and collect data. I couldn't be bothered. It's just too time-consuming. It takes, and the results are really not adequate. So what I've tried to do is get the data which is available online. We don't have the electronic medical record at AKU, but we do have different fragments of electronic data regarding patients, and I've utilized that. So CCMS stands for Critical Care Management Services. This is online data about patients and the procedures that are undertaken on them. You get the surgeon's specific procedures from the same data set, and you can then download this and search for specific procedures, and that's what I did. Now, I then made an Excel worksheet out of it, got the MR numbers from that specific term, and then used the MR numbers on the online patient information, which is PCI. I first went to the histopathology. Thankfully, histopathologies are all online with the date and time, so I could then go back to the operating time from the histopathology. The discharge summaries have become online for the past 15 years at AKU, and they give a reasonably good description of in-hospital events for our specific patients. Our radiology has been on an online PACS system for the past 15 years, and all radiological images, all reports are available online all the way back. We record all our outpatient visits. I don't know what happens in them, but at least the record of the patient coming is there. We have a long list of medications. They're all online, and you can check for them. It's a bit tedious, but you can pick out where chemotherapies were given or what specific drugs were used for each patient. I've used the last day of visit to the hospital by a specific patient to look for survival data, how long they've lasted after the interventions, and that's the sum all of my study. Obviously, patients who came in, have an operation, and never came back to the hospital, they do come for 1 or 2 visits at least. But beyond that, if they've then opted to go somewhere else, cannot be captured by this sort of undertaking. So for right-sided tumors, and I must say here that I'm not going to be talking about low rectal cancers in the sense of abdominal perineal resections. I'm just going to confine myself to the right and left tumors where surgery and restoration of continuity of bowel was attempted. So right-sided tumors from 2011 to 22, I've done 97. These have included the data I'm looking at in extended right hemicolectomies, which I have not included in my study are subtotal colectomies as part of multivisceral resections, part of other procedures like Whipple's, sarcoma surgery, gastric, pancreatic tail cancers, where you might need to take the colon with the primary. Similarly, for appendicular tumors and ovarian tumors, where gynae have asked me to help out, I'm doing HIPEX for appendicular tumors. They're not part of this data set either. This is a trend line which shows the number of cases per year done over this period of time. Slowly they've increased, and it's a consistent pattern with ups and downs. We had a dip in the COVID session, seems to have picked up, and that's where we are. Or that's where I am, let's put it like that. So interestingly, we have, at least my patient group has a mean age of 57. I note that my data set also suggests that about 60%, as the audit report from the earlier in the day suggested, about 60%, 64% are males. I don't know if this is replicable around the world, but we do seem to have more males coming in with tumors. Though there is a question here whether in our patriarchal society males are offered better care and women may not get to hospitals with a similar problem. So that's something to keep in mind, but certainly seeing more male patients with the problem than females. Even though they're in their mid-50s, 60% had one or more comorbidities. That's a huge comorbidity burden, and this relates to our lifestyle and our poor day-to-day living habits. Our patients in their late 50s or mid-50s are like 70-year-olds in Western countries, I think, as far as physiology is concerned. So mean length of stay was about 7 days. Here I must add the day of hospitalization for all of my elective colon cancers. They get admitted the day before. So whenever I use length of stay, this 1 extra day is added to it. So they're actually 1 day has to be subtracted from the thing. So if you look at, this is the discharge data. If you look at about 65 to 70% do get discharged in the first 4 or 5 days of admission. And these are all open surgeries. These are not laparoscopic surgery. People who run into trouble of some form like chest infections, urinary infections, or GI motility issues tend to stay a bit longer. But most get away from surgery about 5 days after an open operation. So 94 out of these 97 were adenocarcinomas, 2 with endocrine differentiation, 1 a complete pathological response. This was an unusual patient who was thought to have metastatic disease to start with. Someone gave him chemotherapy, he responded very well, everything disappeared, and he came in for a right hemicolectomy. Maybe I shouldn't have done that, but did that, there was no tumor there. He's doing fine after that. So if I were to go to the tumors itself, most of our are T3, 70%, and a significant proportion fall in the T4, A, and B category. Again, about 60% come in with node-positive disease, and a small proportion, about 40%, are node-negative at presentation. Differentiation, again, is more or less what you would expect, We've been doing surgery for M1 metastases where the disease is locally involving the surrounding organs, and if we can take it away, we do it. Lymphovascular, perineural, these are bad indicators but are found consistently enough. Like I said, one patient had neoadjuvant. This is not a standard for right-sided tumors, but I think it might become as we come down the line on this. 44% had adjuvant treatment offered. Some of them took it at AQU. Probably most went out because of the cost issues related. I did cytoreductive surgeries and peritonectomy with HIPAC in 5 patients, and thankfully all of them are alive. This is not my routine for colon cancer, but in a suitable patient, I'm willing to undertake that because I think the results can be quite satisfying. So recurrences standpoint, and this is where we fall flat in most of our studies, about 17% of our patients did show recurrences, 11 in the peritoneum, 4 in the liver, pulmonary, and 4 in other organs. The liver ones, I think 3 or 4 out of them underwent secondary resections for liver recurrences. I don't know whether they did well in the long run. That was the last I had on my data set about these patients. Now, if I were to talk about quality indicators in hospital complications, and these are very important, I think, to keep in mind. So nodal harvest is one of the things to talk about. And if 12 nodes are taken, about 5% of the cases, I did not retrieve 12 nodes in my resection. I think that's an acceptable number. I have had 2 anastomotic leaks out of these 97. One was a poor choice patient with advanced dementia, difficult to understand. There was no coherence. The family was insistent that something needs to be done. I took it on board, and she leaked. This was a stapled anastomosis. Most of my anastomoses are hand-sewn anastomosis. This, in my urgency to do the operation, I did a staple. She leaked on the 6th day while in hospital and expired because the decision was not to do anything further for her. One anastomotic leak was after an extended resection. This was managed with secondary laparotomy and exteriorization and then rejoining the ends 3 months down the line. We've had chest infections, wound infections, urinary tract infections, thankfully not to a large extent. Now again, this is in hospital. I don't know what happened outside. I'm sure our wound infection rate is slightly more than what I quote here. We've had our NESCUB data come back from last year, and our wound infection rate overall for our unit is about 6% for colorectal tumors. So this is an underestimate, but this is in hospital data. Right, moving on to the left-sided tumors, and here I've divided them into 2. One is the left hemicolectomy plus minus and high anterior section. I've done 74 of these, and the other are low anterior sections. Now, above the peritoneal reflection, all my anastomoses are hand-sewn. Below the peritoneal reflection, I'd use a CDH circle stapling device. Like I said earlier, excluded the APRs. Patients had a fairly high rate of comorbidities, and again, diabetes and hypertension were the main ones. Length of stay, again, around 7 days. And again, if you look at the days, this was 1 less than what the LOS suggests. This is the trend line. Again, over the years, the numbers have gone up. The length of stay in hospital, again, about 65% leave by the 4th or 5th day of operation. Again, T3, about 73% at T3, 13% T4. Significant nodal positivity in about 50-some%. And again, the distribution of moderate to well to poorly differentiated is the same. Lymphovascular and perineural invasion on histopathology. Neoadjuvant for the left upper tumors, only 3 patients were given neoadjuvant. However, 54% were offered adjuvant treatment following resection. Again, 23% we've been able to pick up the recurrences in this 74 patients, 6 in the liver, 5 in the lung, and 7 others. 2 of these liver sections were suitable for a resection, and one of the lung tumors was again resected. Long-term data is not available for that. Quality of care indicators. Margins were negative. Circumferential margin was positive in 2%, in 2 patients, which is 3%, which I think is quite reasonable considering the type of surgery we're undertaking in this. and our lymph node harvest of less than 12 was again seen in 5 patients, which is 6%. There was no anastomotic leak in these 74 patients. Like I said, all hand-sewn anastomosis. There were wound infections, UTIs, and post-operative ileus was one of the problems we faced in a small bowel obstruction as well. Managed conservatively, all of these. The low anterior section is a smaller group, 55 patients, again, mid-50s, again, males more than females. 58% were given neoadjuvant chemoradiotherapy. Over this 10-year period, we're consistently offering them because most of our patients come in at 3 plus at presentation. So we've had a good response rate. Tumors T0 on resection were 16%. The others showed significant reduction, but this was the best we could get, 16% complete pathological response in our specimen. Again, nodal yield, and here the neoadjuvant therapy is known to affect the nodal yield, so we have a lesser nodal harvest after neoadjuvant chemoradiotherapy, and this, I'm told, and I've looked up the literature, is a finding that's often seen. So the margins here are more important. So the proximal distal margins were negative in all these cases. Circumferential margins, 2 male, 2 female. I thought males would be more, but 2 females were positive as well. Again, like I said about the nodal harvest, 12 patients out of these 50-some patients had less than 12 lymph nodes. There was 4 anastomotic leads with about 7%. These were all managed non-operatively because I make an ileostomy in all of these patients, and most of these patients, 50 out of the 55 in this particular case. They did not require a secondary intervention. Wound infection, urinary infections, mechanical bowel obstruction at the stoma site in 2 patients. We've had to revise the ileostomy. Stomal diarrheas and abdominal abscesses, these were the leaks which were dealt with radiologically. We've had 29% tumor recurrences in this group, mainly pulmonary, liver, bone, and 5 others, 16 tumor recurrences. Some of these are in 1 patient, more than 1 recurrence in 1 patient. So to conclude, thank you for paying attention, but our patients present late. We seem to have male predominance. We have bulky T3 tumors, which are the norm for us. We have high proportion of nodal positivity, approximately 50% in our resected specimens. Ileocolic and colocolic hand-sewn anastomosis are safe and should be the preferred method because of cost implications in our environment. And I still say that you shouldn't throw this particular baby out with the bathwater. Low rectal cancers can be treated with acceptable morbidity after neoadjuvant chemoradiotherapy. And finally, general surgeons need to stay in the forefront of colorectal cancer treatments. Subspecialization is a nice thing, but it's a bit far away for us yet. General surgeons are still the workhorse who are going to be dealing with most of these problems. Thank you very much for your attention. Questions at the end?